I think we'll get started. Good afternoon. I'm Safwan Masri, Executive Vice President at Columbia University for Global Centers and Global Development. I am delighted to welcome everyone who's joining us today, both from within the Middle East region as well as around the world, for this discussion on humanitarian and public sector responses to the COVID-19 crisis in refugee settings. I'd like to start by thanking our partners that we're working with and who are represented here today. Columbia University's Mailman School of Public Health and the program on forced migration and health at the school. The Committee on Forced Migration at Columbia University, UNHCR for the Middle East and North Africa region, and the American University of Beirut. I'm delighted to have with me this morning Professor Monette Zard from Columbia, who will introduce the other panelists, but I'd like to welcome them. I'd like to welcome Shadan Khalaf from UNHCR here in Amman, where I am, Golin Samari and Ling San Lao from New York, and Nasser Yassin from the American University of Beirut. This is the first virtual event hosted by Columbia Global Centers Amman. As we continue to adapt to this new normal that we're living in, we look forward to hosting more such events and sustaining our engagement with a global audience. And I'd like to acknowledge all the wonderful staff at the Amman Center for putting this together, and in particular, Dr. Ahmed Musa and Farah Abdur. This is, of course, an unprecedented moment for the humanitarian sector. Governments and aid agencies around the world are facing the worst crisis of our generation. In the Arab world in particular, and the developing world more generally, COVID-19 is placing stress on systems that in some cases were near the breaking point even before the crisis. For refugees and their host communities, the coming year is going to be enormously challenging as the world fights two battles, one against the virus itself and the other against the economic consequences of flattening the curve, and what may turn out to be the biggest global economic downturn since the 1930s and the Great Depression. Likewise, unprecedented border closures and restrictions on movement will hamper the efforts of the humanitarian sector to battle the pandemic in the places that are most in need of help. In Lebanon and Jordan, two countries with the world's highest refugee per capita rates, roughly 16% and 7% respectively, the humanitarian impact of COVID-19 is undoubtedly going to be significant. As many of you know, the Jordanian government has been effective so far, not only in flattening the curve, but in squashing it, so to speak. To date, with only a few, possibly unreliable exceptions, Jordan has the Arab world's lowest COVID-19 infection rate. Yet Jordan is host to millions of refugees, mostly Palestinian and Syrian. More than 120,000 Syrian refugees live in two densely populated camps, Zaatari and Azraq, while many others have settled in crowded urban areas. For these populations, and indeed impoverished communities around the world, physical distancing is a luxury that few can afford. And tragically, this is now a major challenge for countries like India and Brazil and much of sub-Saharan Africa, especially as winter approaches in the southern hemisphere. Turning to Lebanon, the pandemic comes on the heels of widespread social unrest and a financial crisis, factors that have exacerbated already significant economic and political challenges. Although it has expanded its testing and containment efforts, it is still unclear whether the Lebanese government will be able to eradicate the virus. Like Jordan, Lebanon is host to a large population of Palestinian and Syrian refugees, estimated to be nearly 2 million in total. They live in camps or crowded and impoverished urban areas. As COVID-19 continues to spread, the prospects for refugees in Lebanon look increasingly grim. In addition to illness caused by COVID-19, the unfolding economic downturn may also have serious consequences for the region's humanitarian sector. The ability of Jordan and Lebanon to host large refugee populations depends extensively on support from the international community. But with the IMF predicting that the world economy will contract by 3% in 2020 and that there will be budget shortfalls, there is a possibility that future aid may not be forthcoming. In the coming months and years, we will be forced to, in the words of Emmanuel Macron, think the unthinkable as the global system changes in ways that nobody could have imagined. More than ever before, it will fall upon international institutions, governments, and the humanitarian sector to maintain stability and secure the welfare of the world's most vulnerable populations. And it will also fall upon the world's wealthiest and most powerful countries to transcend national impulses, which have never been stronger, and to help those in need, lest they succumb to populism, authoritarianism, and anarchy. So on that sobering note, I am pleased to introduce my colleague, Professor Monette Zard, who will serve as the moderator for this important conversation. Professor Zard is the Alan Rosenfeld Associate Professor of Forced Migration and Health and the Director of the Program on Forced Migration and Health at the Mailman School of Public Health at Columbia University. Monette previously served as the Global Human Rights Program Officer at the Ford Foundation in New York City and as the Research Director at the International Council on Human Rights Policy in Geneva. From 2000 to 2003, Monette was a policy analyst at the Migration Policy Institute in Washington, D.C., and she held a visiting research fellowship in law at the Refugee Studies Center at Oxford University. Prior to that, she directed the international refugee work of the Lawyers' Committee for Human Rights, during which time her work focused on the use of legal strategies to strengthen refugee protection in Africa. Monette has also consulted on international human rights and forced migration issues for a number of organizations, including Amnesty International, the Brookings Institute, Human Rights Watch, and the United Nations High Commissioner for Refugees. Monette will now introduce today's topic and our panelists. Thanks again to everyone in our virtual audience for being with us. Please join me in welcoming Professor Zard. Monette, over to you.
Thanks very much, Safwan, and good morning, everyone. Good afternoon, wherever you are in this virtual world of ours. It's really an honor to be here with you all and to be chairing this important conversation on the management of COVID-19 in refugee settings. And I can say with confidence that probably all of us on the line today have been impacted in some way by the pandemic and the pandemic response. Our lives have certainly been disrupted, and we're doing things like this that we never could have envisaged even a month ago. But of course, for the 70 million or so refugee and displaced populations worldwide, of which more than 20% are in the Middle East and North Africa region, the challenge has been even more profound of the pandemic and the pandemic response. As Safwan indicated, many of these displaced populations live in overcrowded conditions, not just in camps, but in informal settlements and in crowded urban settings across the region. And in these places, social distancing is more aspirational than real. We know that in these settings, water and sanitation is often inadequate, livelihood opportunities are limited and scarce, and the nutritional status of many of these populations is already compromised. And all of this elevates the susceptibility of these populations to infection. We also know, unfortunately, from the experience of past pandemics, and are certainly seeing that stigma and discrimination will likely intensify and will certainly complicate and undermine our public health responses. And we can also predict with some certainty that as the international community redirects all of its efforts towards battling this novel coronavirus, that disruptions to supplies, that disruptions to the movement of healthcare workers, and the upending of routine health services will end up leading to many more deaths possibly than COVID-19 itself. And we are already seeing, I think, the resurgence of Ebola in the Democratic Republic of Congo, the disruption to efforts to combat cholera in Yemen. All of these things are likely to be intensified and will complicate the response. Finally, of course, as Safwan mentioned, the knee-jerk reaction to close borders and to impose travel restrictions in an effort, perhaps futile, to try and control the spread of this disease will also have very profound effects on refugees and displaced communities because, of course, the conflict and the violence that they are fleeing haven't stopped for the virus, and they continue unabated in most places. But of course, there are also opportunities that come out of crises, and I think we would do well to try and identify some of them early on and see if we can work to capitalize on them. So first, I think, is the beginnings of an understanding of how interlinked our health is, that the health of our society really rests on ensuring that the most marginalized amongst us have access to testing and to adequate healthcare to contain the violence. It's not an either or. We have to lift up all boats in our response and ensure that everyone can access testing and care. Secondly, in the humanitarian context, as international staff become increasingly restricted in their ability to travel, the promise of localization may end up bearing fruit. Whether we like it or not, localization is the only game in town, and of course we need to make it work. But we must make it work in a way that doesn't just shift risk to frontline workers from amongst refugee and communities battling with the pandemic. We have to do it in such a way that equips them with the personal protective equipment, with the resources they need to mount both a safe and effective response. And then finally, I think we are seeing a growing realization that amongst the refugees and displaced communities themselves, there is this incredible resource of refugee medics, health workers, doctors, nurses, that could end up being critical to mounting an effective response in many places in the world. So even in places like Germany, we see a speeding up of certification processes to allow immigrant and refugee doctors to be able to practice. And so again, I think looking around the world, there perhaps are these glimpses of how we can use this crisis to perhaps transform in a positive way what our humanitarian sector looks like. So to explore some of these issues and of course some of these challenges, we have an extremely distinguished panel of speakers with us today, and I'm going to introduce them to you. Our first speaker will be Dr. Ling San Lau, who is a senior program officer with the Program on Forced Migration and Health at Columbia University. Dr. Lau is a pediatric doctor with professional experience bridging clinical medicine, public health and research, and she's really dedicated to improving the health of both children and families in contexts of conflict, communicable disease, and forced displacement. So her remarks will really help frame some of the global challenges in terms of the humanitarian response. Our second speaker today will be Dr. Golene Samari, and she is an assistant professor in the Heilbronn Department of Population and Family Health. Dr. Samari's research as a public health demographer centers on the rights of marginalized communities and addresses public health disparities due to migration, gender, and discrimination. And her work looks at these issues both in the US as well as globally, with a specific focus on the Middle East and North Africa region. And so her remarks will really focus on the gendered impacts of the public health response that we're seeing and issues of discrimination. Our third speaker will be Ms. Shaden Khalaf, who is an international expert on refugee and humanitarian affairs in the MENA region, currently serving as the senior policy advisor at the United Nations High Commissioner for Refugees in their MENA office in Amman. Shaden has catalyzed and spearheaded the design of innovative partnerships with civil society, academia, and the private sector on refugee issues, working through the MENA Civil Society Network for Displacement. She's also previously lectured at the Department of Law and the Center for Migration and Refugee Studies at the American University of Cairo, the AUC, and she's published extensively on displacement in MENA. And she will speak about the UNHCR's approaches to managing the pandemic in the region. And then finally, we have Dr. Nasser Yassin, who is the interim director of the Essam Ferris Institute for Public Policy and International Affairs, and an associate professor of policy and planning at the Health Management and Policy Department of the American University of Beirut, the AUB. He co-chairs the AUB for Refugees initiative that brings together and builds synergy amongst faculty and departments at the AUB responding to the Syrian refugee crisis. He researches and advises on policy and social innovation, especially in the areas of youth, health, and refugee policies and programs. And his work looks at issues of civil society and community and informal networks and how these can influence policies. And so he will reflect on that in his remarks, looking at the role of civil society in Lebanon on preventing stigma and so on. So each of our speakers will speak for about 10 minutes, and once they are all done, we will open it up for a Q&A, and that Q&A will be handled through written questions that you'll be submitting, I hope, over the course of these presentations that we're going to be listening to. So without further ado, I'm going to hand over to Dr. Lau San.
Thanks, Professor Saad, and thank you to Professor Safwan and the team at the Global Centre for bringing us together for this discussion. It's great to be here today. So just while we're bringing up the slides, I want to give a brief overview of the global context. Currently, 213 countries are reporting cases of COVID-19. And we're approaching 160,000 deaths worldwide. More than half of the world's population is in some form of lockdown due to COVID-19, including many of us who are calling in today. 93% of the world's population live in countries with COVID-19 related travel restrictions, and this includes 3 billion people living in countries that have completely closed their borders to foreigners. Some countries are using COVID-19 to deny asylum or to refuse repatriation of their own citizens, and refugee resettlement has been halted globally. The IOL predicts that the equivalent of 195 million jobs will be lost by June. Informal workers are particularly vulnerable, and they account for more than 60% of the global workforce. We know that refugees and other displaced populations are among the most vulnerable people during a pandemic. As Mehmet mentioned, they often experience inadequate living conditions, poor nutrition and health status, and limited access to healthcare that can substantially increase the risk of COVID-19. They often live in contexts characterised by conflict, social, political and economical challenges, and fragile health systems. We also know that refugees and other displaced populations bear the burden of control measures, including lockdown orders, border closures, loss of work, and other socio-economic consequences. Our PFMH faculty are playing a key role in the COVID-19 response, and they've responded previously to epidemics including Ebola and SARS. I'm here to share their collective wisdom and to highlight some of the public health messages that our program has been communicating. These relate to the indirect impacts of the pandemic, the need for a global response that is inclusive of displaced populations and other vulnerable people, and the importance of community engagement and trust. We know from previous epidemics that indirect impacts exceed the deaths and illness caused by the disease. The indirect effects can result from the diversion of funds, personnel and resources to the pandemic response, disrupted supply chains, overwhelmed health systems, healthcare worker shortages, reduced humanitarian access, and interruptions to routine health services and prevention and treatment programs. Restrictions on movement, reduced access to transport, and fears of contagion can also mean that people are less likely to seek healthcare when they need it. We saw these effects during the Ebola epidemic in West Africa, where excess deaths from measles, malaria, HIV, and TB exceeded deaths from Ebola. We saw a similar pattern in the US during the H1N1 influenza pandemic, when more people died from stroke, heart attacks, and heart failure in overburdened hospitals. And we are seeing these effects now with COVID-19. In New York City, an average of 200 people have died at home each day during the peak of COVID-19, a 10-fold increase compared to baseline. These at-home deaths were in addition to an average of 245 deaths each day, which were directly attributed to COVID-19. It's not possible to know how many of the New Yorkers who died at home had unconfirmed COVID-19, but we can safely assume that a proportion of these people died from other diseases. It's disturbing to contemplate the effects of COVID-19 in countries with weaker health systems and where data may not be as readily available. As Manette mentioned, we are already seeing the re-emergence of Ebola in the Democratic Republic of the Congo and the suspension of measles vaccinations as DRC battles COVID-19 amidst the worst measles outbreak in its history. Our alumni working in humanitarian settings around the world have reported significant disruptions to the humanitarian response as a result of COVID-19. They highlighted the urgency of preserving essential services and responding to other important needs in their communities, such as food crises, locusts, and violence. While we combat COVID-19, we cannot afford to lose sight of the other important causes of death and suffering around the world. Our second message is that the global COVID-19 response must include displaced populations and ensure that they have comprehensive access to prevention measures, testing and treatment alongside other populations. This is especially important at a time when personal protective equipment, testing resources and ventilators are scarce, and many countries are prioritising the needs of their own citizens. Such approaches are short-sighted. It's often said that during a pandemic, we are only as safe as our most vulnerable neighbour. One country leading by example is Portugal, which has granted non-citizens equal rights during the pandemic, including the right to healthcare. Ensuring access to timely, accurate information is also vital for an effective response. In Bangladesh, more than 1 million Rohingya refugees lack access to important information about COVID-19 due to internet blackouts. Around the world, we are witnessing widespread uptake of restrictive measures such as travel bans and lockdowns without the same attention to supportive measures required to promote public health. These include access to social services, healthcare, sick leave, and other worker protections. For many people living in poverty, lockdowns mean a choice between starvation and contagion. Provision of food assistance, social services, and income support is essential in these circumstances. An inclusive and comprehensive COVID-19 response needs to be sensitive to the needs and challenges on the ground. Many of our public health messages, for example, around social distancing or home isolation, are difficult or impossible to follow in humanitarian settings. This is a picture of a camp in Greece which houses 20,000 refugees in a space designed for 3,000 people. In camps, detention facilities, and high-density urban areas, shared cooking facilities and latrines are common, while wash facilities are scarce. The Interagency Standing Committee has issued guidance about responding to COVID-19 in humanitarian settings, including crowd management and adapting food distributions, but we need better evidence about what works and what is feasible in these settings. Our final message is that pandemic control relies on the trust and engagement of affected communities. This was one of the most important lessons from recent Ebola epidemics, where many of the public health failures stemmed from a lack of meaningful participation of the people who were most affected. Community leaders, including imams and other trusted figures, played a central role in curbing Ebola. Displaced populations have a critical role to play in the COVID-19 response, and they need to be equipped with the information, resources, and support to do so. For example, the valuable role of refugee health workers is being increasingly recognised as countries including Germany, Canada, and Spain seek to leverage their skills. Unfortunately, displaced populations, including refugees and migrants, are often stigmatised and unjustly blamed for the spread of disease. Travel bans, when combined with populist rhetoric, can fuel fear and stigma and undermine public health goals. One of our first lines of defence against COVID-19 is the willingness of people to come forward with symptoms and to seek care. The quote on this slide is from a paediatrician who is witnessing the consequences of the world's largest lockdown in India. As we confront the COVID-19 pandemic, our actions and our inaction carry a cost. We are accountable not just for the course of this pandemic and the measures we choose to control it, but for the people who stand to lose the most and who bear the greatest cost. Thank you. I'll hand back to Professor Zard.
Thanks so much, San. Given us a lot to think about there. And I think without messing about, I want to also move on now to Golene and have her add to our discussion on this.
Okay, I'm going to try to share my screen. Let's see. Does that work? Can you guys see the slides?
Yep,
Yes.
we can see it well.
Okay, perfect. So I'm briefly going to build off of what Dr. Lau was talking about and talk a little bit about xenophobia and discrimination that's been associated with the response, and then I'm going to move into some of the gender-based issues. So like Dr. Lau mentioned, the health of every person is linked to the health of the most marginalized members of the community. And I think COVID-19 really challenges us because there's no room for the traditional paradigm of host community versus migrant communities. We really have to be inclusive of health for everybody in order to beat this pandemic and move forward. So treatment really needs to be available to everyone without discrimination. This means that no one is denied treatment because they lack the means to pay for it or because stigma prevents them from getting treatment. In the past, there's been inequitable access to care along different lines like income, gender, geography, race, ethnicity, religion, or migration status. And there's just no room for that in the response. So Dr. Lau touched on this a lot, but migrants and refugees, regardless of their formal status, they have to be an integral part of the national systems and plans for tackling the virus. And unfortunately, a lot of people are already saying that migrants and refugees are the human cost of coronavirus. So I think it's important to really characterize the viral transmission of xenophobia because wherever a pandemic goes, xenophobia is not far behind. The us versus them fear-mongering is really common in pandemics. I mean, Italian immigrants were scapegoats for the New York City polio epidemics in 1907 and 1916. Cholera was called the Asiatic cholera in the 1800s, and tuberculosis was called the Jewish disease in the 1900s. And there's countless examples of this with any epidemic and pandemic outbreak. These acts of discrimination really occur within social, political, and historical contexts, and unfortunately, political leaders have misappropriated the COVID-19 crisis to reinforce racial and xenophobic discrimination. For example, border policies that conflate public health restrictions with anti-immigrant rhetoric. So we've seen countless examples of this, physical attacks against the Chinese and other Asians, blaming Roma and Latinos for the spread of the virus, restrictions and racism towards Africans in China, and overall denying migrants access to health services. I was thinking about the progression of xenophobia and stigma throughout COVID, and it started really centered on the Chinese, broadened out to East Asians overall throughout the world experiencing discrimination and violence and things like that. And then it has really expanded to migrants as a whole. So now the response is really focused on migrants, and there's intersectional and disproportionate impacts on women and girls. There's been reports of UN and humanitarian aid workers being thought to bring in the virus into refugee camps and settings, and so there's been acts of discrimination there. And there's been reports of recovered patients, like in Egypt, for example, there were reports of stigma of those who have had the virus and recovered being mistreated. I think it's important that we really center around the messaging that getting the virus is not a shame. It's really part of being human, and centering around the response around the virus and not the people affected by it. It's also important to recognize that all of these acts of xenophobia and stigma are really part of the global response. So the way that we have responded to this virus has propagated the xenophobia against all of these groups. So it's important to really be mindful of that in our response moving forward. Just to highlight some global migration restrictions that really demonstrate this. So in Qatar, there's a lockdown of migrant workers. In Kuwait, an actress said on TV that migrants should be thrown out into the desert. Singapore just locked down thousands of migrant workers. In Lebanese municipalities, there's restrictions targeting Syrian refugees. And while these are not new necessarily, these curfews are being enforced sort of outside of the law, and they don't apply to other foreigners. The US southern border is closed to all asylum seekers. And as we all know, it was tweeted last night that the US president wants to shut down immigration entirely. So how do we disrupt this xenophobia? We really have a duty to combat all forms of xenophobia, stigma, and discrimination. States should take concrete, deliberate, and targeted measures to address this discrimination and stigma, including implementation strategies, policies, and plans of action to address actions by public and private actors and protect all individuals from mistreatment. We have to, like I said, shift the narrative surrounding the crisis. The virus is the enemy and not the person who is infected. And inclusive approaches to health for all are the only way forward. Just to build on this a little bit, to talk about the gendered aspects of the response, refugee women not only experience the xenophobia that migrants are facing, but they also have intersectional disparities that they're experiencing because of gender-related issues. These are some headlines, but for displaced women and girls who account for over 50% of displaced people and whose needs are invisible even in normal times, the health risks posed by COVID are really huge. And it's really important to recognize that pandemics are not gender neutral. We know from previous outbreaks like Ebola, Zika, and SARS that pandemics reinforce traditional gender roles of care. They reduce access to sexual and reproductive health services. And that's either because of shortage of supplies, medicine, or specialist health workers, or because resources are redirected in times of crises in ways that reflect the priorities of generally male policymakers rather than the needs of women. Just to highlight some of the gender-based inequities that are already being observed. So restrictive public measures like physical distancing and quarantines are increasing exposure to gender-based violence. There's some reports of sexual violence, survival sex and child marriage in refugee settings. Sexual and reproductive health services are integral to the response. Pre and postnatal care are vital. There's been reports that 9.5 million women around the world could lose access to contraception and safe abortion. Another gender dimension that's often highlighted is that women have increased caregiving responsibilities, and over 70% of frontline and healthcare providers are women and girls, and these are often migrant women. So there's been a recent statement by the UN Working Group on Discrimination Against Women and Girls, which basically says that many women face multiple and intersectional forms of discrimination and are at further risk of being marginalized, and so they must be included in the response. In the context of COVID-19, domestic and gender-based violence helplines and shelters across the world are reporting increases in calls by as much as 30% or more in some countries. There was a report out of Lebanon that groups have seen a 60% jump in gender-based violence cases. If these issues are not addressed, the consequences for migrant and refugee women and girls will be catastrophic in terms of access to contraceptives, medicine and personal hygiene products, increases in unwanted pregnancies, lack of access to safe abortion, increased risk of maternal and infant morbidity and mortality. And basically these things undermine every principle of autonomy, equality, and dignity for women and girls. So what can be done? One measure could be ensuring that services for survivors of gender-based violence are designated as essential and remain accessible. So we need to continue to have effective referrals, accessibility of avenues of safety, psychosocial support, safe shelters, and access to justice. We need, UNHCR has been distributing emergency cash assistance to support survivors and women at risk, and this is important and should continue. And the risks of violence for displaced women and children must be taken into account in the design of national COVID-19 prevention, response, and recovery plans. There's lots of examples across the world. So in Chile, for example, women have launched a feminist emergency plan that includes coordinating caring duties and mutual support against gender-based violence. In Lebanon, a local organization is providing vital public health information. They're offering psychosocial support sessions via conference calls and WhatsApp groups, saving face-to-face interventions for high-risk cases. So also, in terms of essential services, sexual and reproductive health care needs to continue to be essential for all those different services that I've mentioned. And really the message is to not divert resources away from these essential services, because not only do they exacerbate poor reproductive health outcomes, but they also exacerbate the COVID-19 pandemic itself, because women will have to either travel further to seek care or have more interactions to seek care, which just increases exposure and potential transmission of the virus itself. So the ways forward is really to prioritize, invest in community-based organizations. Really, localization, like Professor Zard and Dr. Lau have said, is really, really key to how we move forward. It's also important to offer financial flexibility and extended deadlines for grants and funding opportunities. We should ensure that COVID-19 information and care is accessible to all women and girls. They really should be involved in the response, and it's just as decision makers as well. We should acknowledge that women and girls experience the COVID-19 crisis differently from men and boys. Segregating the data by age, gender, and disability will really make sure that nobody falls through the cracks. And importantly, there needs to be program continuity, staff safety, and frontline response that continues and really is mindful of all of those involved to offer continuity of care. Just to highlight the resilience and power of women and girls in the response, there's been a lot of efforts around the world of refugee women really rallying to respond for their own communities. So, for example, in Rohingya communities, women and girls have been mobilizing and formalizing networks to raise awareness about COVID-19 across camps. In Iran, refugees are making masks and other personal protective equipment. In Jordan, Syrian refugee women are making and distributing soap to support good hygiene. In Switzerland, Syrian refugee volunteers are shopping for the elderly and others who need to stay home. In Colombia, we have examples of activists performing online skits to teach nonviolent ways to handle real-time frustrations and family conflicts during the pandemic. I think these examples can really lead the way to show that refugee women are integral to the response to fight the xenophobic messaging and really make the world a healthier place. Thank you.
Thank you. There you go. The technology challenges those older members of our community sometimes, so I couldn't find our unmute button. Thank you so much, Golene, for that. I think your points have really reinforced that even amongst a population that is already, vulnerable in different ways, there are even specific sectors that we need to be mindful of in our programming and in our approaches, and building out on some of those resilience that is also demonstrated in these communities is really important. So thank you for sharing those comments. I'm going to move on next to hear more about UNHCR. So Shad and Khalaf, if you don't mind, you're up.
Just quickly try to share my screen. Hoping that will work quickly. Yes, I think so. Great. So thank you. Also, let me add my words of appreciation to the Columbia Global Centers, to Professor Masri, to Dr. Ahmed Musa, and all of the the friends and colleagues who have put this together. It is, of course, always a pleasure to be in partnership with you, even though, of course, the topic at hand today is one that is a sobering one, as Professor Masri indicated earlier. So what I'd like to do today is talk about three main things. First of all, I would like to talk about the impact of the global pandemic on the refugee population in the MENA region. And then I want to talk about what is being done to address this situation. And thirdly, offer some thoughts on what can we envision as a potential way forward, and actually noting a lot of similarities with what the colleagues before me have said. So just to build on that also and to add more momentum to that. So I'll start by giving a quick overview of the situation in the region, which has also been touched upon briefly by some of the colleagues before me. The MENA region continues to be one that is very much characterized by fragility and instability at many levels. They really do remain defining characteristics, I would say, of the region on many levels. It is also a region where armed conflicts have for years been ravaging, devastating economies, infrastructures, and lives of millions of people. And what we're seeing is that the gains that could have been made in achieving the sustainable development goals for the populations of the region have unfortunately continued to not be at the level that we would like them to be. And this is also a factor, obviously, of the fragility that has been induced by conflict, among other things, over the past few years. The third point that I'd like to make on this regard is that the region hosts, by our count, 40% of the world's total displaced population. So this is quite a significant proportion. Some would call it disproportionate, actually. And it highlights the fact that most countries in the region are either countries of origin, transit, or destination for people who are forcibly displaced. And this highlights, of course, the importance and the structural importance of addressing displacement and preventing displacement in a very comprehensive and inclusive manner in the region. So what does this mean in relation to COVID? So, of course, it was also highlighted by Professor Masri that this very pressing global public health crisis is very quickly turning into one of the biggest socioeconomic challenges that we are likely to see in our lives. And I think it is doing two things at once, and I'll try to explain how I see this. So I'm calling it at once the ultimate equalizer, in the sense that the virus does not discriminate. The virus does not distinguish between a refugee or a national or an IDP or a stateless person. And we're all susceptible to it. We're all at risk of falling ill and dealing with the consequences of this illness. And in a way, it's highlighting what we have been advocating for years, and that is inclusion of refugees in national health access and general health facilities. At the same time, it's doing quite the opposite. It's doing what I'm calling extreme exacerbation of existing inequalities. So it's taking the structural issues and challenges that have existed in the past, the ones that I mentioned earlier, and really catapulting them onto a whole new level of reality. And so existing vulnerability is being heightened, existing poverty is being deepened, and existing gender inequalities, as we just heard from the colleague from Gulin just before me, are very much being crystallized and highlighted. So what this goes to show, I think, is that there is no way around working through a global approach, a comprehensive approach to addressing the very real impact that this is having on people's everyday lives. But at the same time, it has to be very nuanced and very tailored to the local realities on the ground in each country and in each community. So what are the actual more specific types of impacts that are being had, that are unfolding, I should say, in refugee settings? So we now know that all countries in MENA have been affected by the virus, and according to ESQA, about 55 million people in the region who are in need of humanitarian aid are potentially at risk of contracting the virus. And here, this is just a quote from the UN Secretary General on the need for these consolidated and collective global response approaches, which I just mentioned. In the interest of time, perhaps I will move forward, but happy to share this for those of you who would be interested. In terms of specific protection impact on the persons of concern to UNHCR. So definitely the issue of daily livelihoods for the large majority of refugees who we know in general to have precarious access to livelihood opportunities is an issue that is very much high on our radar. Other issues are including the impact, the result of that limited access to livelihoods and economic marginalization to many people having to resort to negative coping mechanisms, which many of you would probably be familiar with. The restricted access to asylum, the limitation of our ability to continue to register and document persons of concern in general, and specifically issues related to gender-based violence and prevention, the disruption of education, the increase in psychosocial needs and mental health issues, and of course children are particularly vulnerable in situations like this, and we are in many instances are already preparing for a potential increase in child labor, trafficking, and other issues that often arise in situations similar to this. What is UNHCR doing to try to respond to this? So our High Commissioner Filippo Grandi recently had a conversation with a number of international NGOs on the COVID response in general and their role in it, and he defined our role in, or our vision, let's say, for how we are responding along the following lines. So the first and foremost priority is inclusion in national health systems, which in a way is seems pretty self-evident, and by and large most countries in the region do see the logic behind that and understand that this is in everybody's interest, including their own as governments and their own nationals and citizens' interests, as well as that of the refugees. So that continues to be our number one priority in terms of advocacy with national authorities. The second and more perhaps complex area of advocacy is inclusion in and support for socioeconomic inclusion in national social safety nets and social protection and so on. And this is something which is perhaps a little bit more longer term, and the impact of which we will need to continue to work on, but it is of crucial importance given the highly negative socioeconomic impact that we are seeing unfolding as described earlier. The third area is the vigilance on the protection issues, which were also highlighted by some of the previous speakers, meaning the restrictions, the lockdowns, the closure of borders. And what we are trying to ensure is that we don't fall into a pattern or into a system of permanence for these lockdowns. We understand, of course, that some of them have to be in place and that states will do what states need to do to protect those on their territories. However, what we are trying to be mindful of and ensure that our counterparts are mindful of is the need for there to be continued revision of the need for these measures to be in place, and continued understanding of their impact on various populations in different ways. The fourth area that is, of course, critical for UNHCR as a frontline humanitarian agency is staying and delivering. How can we continue to ensure that our operations continue to run, that we are still able to serve the people that we are here to serve, given the restrictions on our own movement and on our own staff's potential, the risks to our own staff as well. So this includes, it's relevant to a lot of our NGO partners as well, and to the extent possible, we are continuing to advocate that humanitarian workers have the same, let's say, ease of movement, or that restrictions on the movement of humanitarian workers and those who are essential to delivering key services to refugee populations are ensured. So maybe what we can do now is look a little bit at the key areas of the response very specifically. So we have, maybe we can categorize them into three phases. The first would be the prevention and awareness, and engaging the community in raising awareness about health and sanitation, and how to protect themselves and protect their communities. The second one would be containing the transmission to the extent possible, meaning looking at how we can reduce movements, how we can create spaces for isolation and quarantining, given what we know and what we see, of course, about in terms of the densely populated areas where many of the refugee populations live. And the third phase is, of course, treatment and case management and follow-up with individuals, and also ensuring that they are not facing the stigma and discrimination that was also mentioned by my colleague just a few minutes ago. So we have examples from the region, if that would be perhaps of interest to some of you. So we see in situations where conflict continues to ravage countries like Libya, where we are working with our partners on the ground to make sure that their healthcare capacities are reinforced and that they are able to amplify the messages, excuse me, that we are sharing in terms of awareness and about health and sanitation. We're trying to provide generators, ambulances, prefabricated containers, and tented clinics in support of local healthcare providers, given, of course, the very precarious local context in Libya. In other parts of the region, many of you are familiar with the Zaatari camp. We're trying to implement social distancing. We are trying to the camp was closed off for very early on. Actually, the government of Jordan took very strict measures to ensure that entry and exit out of the camp was extremely well controlled and monitored. Temperature screening is conducted at the entrances of the camp. School for children who used to attend school inside the camps is now broadcast. We have ensured that the number of hours of electricity provided, for instance, to the different families has been increased to allow children to continue to carry out this home-based schooling to the extent possible. Cash assistance continues to be provided to help families cope with the increasingly limited employment and opportunities and the difficult economic conditions. And of course, we are planning to build designated areas, as I mentioned before, that would help for self-isolation and be, in a way, temporary shelters for those who may contract the virus in the future. In Lebanon, and perhaps Dr. Nasser Yassin will speak more about this in a minute, we are doing the same, trying to build isolation facilities wherever possible, working very closely with civil society organizations and local community-based groups to do that. Also trying to support expanding intensive care units in hospitals where refugees as well as Lebanese citizens would have access. So increasingly, as I mentioned, making sure that our approach is one that is inclusive and comprehensive. So anything that is provided is aimed at supporting the prevention or treatment for both nationals and refugees as much as possible. And we are also working on identifying trained health professionals within the refugee communities who can also play an important role. It was mentioned by earlier that that's happening in Germany. We're happy to see that this is also, we see the beginnings of this happening in Lebanon, which is a highly positive development. And given the conditions that we know in Lebanon and the very precarious situation there, I think this can be a very positive development in a rather grim situation. Otherwise, we have, I can go on with more examples from the region, distribution of hygiene kits in Syria, Yemen also, which has cash assistance I mentioned. Yemen, where we already know that the world's largest humanitarian crisis continues to unfold, distributing hygiene and sanitation kits, conducting trainings on safe behavior, and identifying the individuals who would be at highest risk and making sure that they receive the immediate care that they would need. We are, of course, not working in isolation on all of this. We are part of the bigger global response, and many of you will have heard that a few weeks ago, the Global Humanitarian Response Plan was launched by the Secretary General of the UN and all participating UN agencies. And this amounted to an initial estimate of $2 billion required for the response for the coming 9 months. And now already just a few weeks in, there is an evident realization that this amount will need to be revised. And we are already working on a revision of the $255 million requirement that UNHCR had put in place. And the new figure will be coming out in a couple of weeks to show, and this is really highlighting the extent to which the needs are growing at an incredibly fast pace. And to the extent possible, we will need to be conducting a prioritization exercise because it will have to be a staggered approach. We have to be highlighting which countries are in the biggest need, or have the biggest need, and have the largest refugee populations, and where the health sectors and infrastructures need the most reinforcement. So it's a difficult exercise to undertake, but one that is necessary, and one that also relies on the very generous support of a lot of our key donors and partners. Maybe now moving on to just one final point in the interest of time. I think that it's very important to highlight, and maybe this will be a transition to Nasser Yassin's intervention, the role that civil society can and should and is playing in relation to the response. So we've heard so far from, I think, every one of the previous speakers about the importance of localizing the response. So this is really something that I would like to add my voice to, and referencing here the fact that the Global Refugee Compact, the Global Compact on Refugees, which was adopted a little over a year ago, is very much calling for this whole of society approach to responses in general. Now we're seeing that this is perhaps the first practical test of how to operationalize this on a daily basis. How can we effectively include faith-based organizations and academics, institutions like yours, and civil society organizations, the private sector, artists and cultural influencers, who all have a role to play in shaping the narrative and strengthening the response and ensuring that everybody is receiving, or to the extent possible, receiving the preventive and palliative care that they need. So it's a work in progress, and it is we're met with different levels of success across the region, of course, given the context in many places, as we know it, to be challenged by ongoing either conflict or difficulty for civil society to operate. But I think what we're seeing is the beginning of a very positive awareness or rediscovery, if you will, of the importance of the role of all these civil society actors. And I'll end here perhaps with this.
Shadan, I think we're probably going a little bit over time, so
yes, this is my last slide.
Step in and maybe ask Monette to bring in the final speaker so that we have time for the Q&A.
A little bit of Q&A, sure. I'm kindly though, Shadan. Is there one last thing you want to say?
No, I was just going to reference this Chinese word, which means crisis. I mean, the translation of the Chinese word crisis is apparently can be broken down into two components, meaning danger and opportunity. So I thought that would just be a fitting way to conclude. Thank you so much.
Thank you so much. So Nasser, over to you. If you could keep to your 10 minutes, even a little bit briefer, that would be great, because we have quite a list of questions forming. So over to you, Nasser.
Yeah, thank you very much. I'll try to be brief, and if I exceed 8 minutes, just let me know. I'd like to say a couple of words on, and to start with the background that Lebanon has been going through, the context of Lebanon. And, before the COVID-19 outbreak, before all the lockdown, Lebanon was going through one of its perhaps worst economic and financial crises in its history. Of course, this is happening with a political crisis, if I put it this way, huge demonstrations, unprecedented in Lebanon, that actually kickstarted in October of last year, with thousands of people taking to the streets. So there's a political crisis in the sense that the people are challenging the political elite, they're challenging the way they've been managing the state and its economy for the past decades. And they request something different. They request a state that actually can cater for their rights. And of course, we started with the uprising that, as I mentioned, started in October of last year. We started to realize the extent of the crisis we are in. Lebanon is going now through a twin deficit, as they say it. There's a deficit in the balance of payment. Was going really in an unsustainable trend in the last couple of years. And there's also a fiscal deficit in terms of the government spending All of this being now realizing that banks are also becoming insolvent and they're unable to pay the money to their clients. This is, immense in the sense that the expectations before the COVID-19 that the economy was going to shrink, of course. There's devaluation of the Lebanese currency, of the Lebanese lira. Is actually the market rate now is double the official rate. All of this actually means there's a huge pressure on the working class and middle class and everyone, as a matter of fact, but particularly working class and middle class communities and groups in Lebanon, and of course on refugees, and those are the most vulnerable. So, some has portrayed this as really the perfect storm, with all the pressure that's actually happening on Lebanese from different ends, and then COVID-19 comes in. And this is going to be massive, and everyone is going to expect that the repercussions of the COVID-19 are going to be immense on the Lebanese economy and the Lebanese society. And I'll explain in a few minutes what's going on in terms of the response to COVID-19 and how the repercussions are going to be very dire on Lebanese as well as on the Syrian refugees and other refugees who live in Lebanon. First, I'd like to say that the response to the COVID-19 by the government and by the Ministry of Public Health and by the healthcare system has been good, as a matter of fact. The lockdown started early. So today we only have 677 cases. 677 cases may not be the best indicator, given that the number of tests, the daily tests, is still around 500 or so. But actually, when you look into other indicators in terms of the critical cases and the number of deaths, there are only 3 deaths per million, which actually the global average at the moment is 20. And if you look into Spain, which has had hardly and hit, is actually around 429. So Lebanon has managed to contain the outbreak due to people's actually adherence to the lockdown and due to the quick response from the authorities to respond to the cases that most of them actually came because they've been traveling abroad and they infected their families, and then it spread around their communities. So for that, we're probably witnessing a control to the outbreak, and we might even start a release of the lockdown or an exit very soon. I expect it maybe in the next couple of weeks. But as a matter of fact, when we're just going to be going out and realizing what happened to our economy and to our society, I think we're going to regret that we left our homes. I was telling this to Dr. Safwan now. We're going to see a very, very dire situation in terms of people losing jobs. Now, before the COVID-19 lockdown, the expectation that there will be 300,000 jobs lost in the first quarter of 2020. And I think now with sectors like the services sector, like the restaurants, tourism related, all those who actually do the retail industry, the retail sector, and they were hardly hit by the lockdown for the last 6 weeks or so. And I think they're going to see people put redundant. Some are actually going to close down their businesses, and it's going to affect a large number of people. Now, when it comes to refugees and a lot of their host communities, because most of refugees, almost all of them, live among the poorest Lebanese, the situation is even worse. And 55% of the Lebanese economy works in the informal sector. And when we look into between Lebanese and refugees, around 97% of refugees work in the informal economy. And those actually, most of them, except those who work in delivery sector, like they deliver stuff, actually have been hugely affected by the lockdown. And some of them are trying to break the lockdown and look for jobs, and they've been faced by the police. So this is going to be one of the major repercussions to look for, and to try to understand and monitor and actually see how we're going to react to it. I don't see major remedy for this repercussion, because as I mentioned early on, the economy is really bad at the moment, and we're going through a lot of you know almost a meltdown of the Lebanese economy and its financial system. On the other hand, the COVID-19 gave a breather to the political elites and political class, and people, because of people stayed home, they actually were kind of released from the pressure or relieved from the pressure that was actually taking place on the streets since October. And they started to recreate their, or to re-oil their political network, their clientelist network, distributing food rations to families, or cleaning kits, and so on and so forth. So also this is we're going to face this reality at the moment that some of the political groups and political parties and those in power kind of re-oil their machine in order to re-emerge from the COVID-19 lockdown as if they were actually in charge of limiting the spread of the disease, and by being closer to their community, and so on and so forth. And the third one, as a matter of fact, is the control that we've seen practiced by the authorities on everyone, including the protesters, the Lebanese protesters who've been on the streets for the last few months, but also on refugees in particular. And as my colleagues mentioned early on, because refugees are the softest target, they're the weakest in the community, they're easily targeted. And when municipalities in Lebanon, municipal authorities started to practice some kind of limiting movement, checking people who come into their towns or villages, their first the first target was to hit on refugees and to target the refugees and to actually curtail their movement. And whenever I talk to some of the mayors and some of the councillors and some of the municipal authorities, and I say, listen, but this is a virus that can spread across all communities, rich and poor. You cannot actually single it out because the refugees are living in dire situation, or they have living in tents or in places. Of course, they are at higher risk, but you cannot single them out. The spread of the virus is going to happen regardless of this, because actually it's a social disease and it spreads fast, just making it simple for them. But yet we've seen a lockdown, we've seen municipal police going after refugees. We've seen also some tension taking place with refugee communities, and I expect this to get even worse. So what we've been trying to do at the moment, we're trying to look into, of course, the actual repercussions of the COVID-19 lockdown, and how actually it accentuated, it compounded the economic and financial crisis. And particularly, we want to look into refugees and their host communities. The expectations of the World Bank and other organizations that the Lebanese are going to, the poverty is going to increase to reach around 50% of the Lebanese, and 73%, according to the UNHCR survey, 73% of refugees are living below the poverty line. So you can imagine the amount of need that those communities, 1 million poor refugees, and perhaps another 2 million poor Lebanese are going to be in need. The economy is going to shrink, as I mentioned, the expectation is around 12 points. So this means a lot of unemployment is going to happen. Now, don't see an answer to this, except that Lebanese will just try to migrate and leave the country, but also refugees are going to be in a critical situation. They cannot return at the moment to Syria because of many reasons, and they cannot leave because of the limited ability for them to move around, and the policies in Europe and elsewhere. So what we expect, that a lot of tension is going to take place. And we've been seeing some anecdotes around this, and this is what we're trying to do. We're trying to monitor further this tension. We're trying to look into ways to work with local communities, with the municipal authorities, with the communities from the refugee, and as well as the host communities, in order to let them actually understand that this crisis is affecting them both, and no one is to be blamed for it. But unfortunately, it's not so straightforward, because when they notice a refugee family taking whatever small amount from the cash machine, and a Lebanese family now has lost their source of income, they're going to actually stand against each other. So this is at the moment what we're trying to do. Another area that some civil society groups are working on, and this is the last
Thanks. Great, thank
is
you.
the issue of eviction, because because of the lockdown and because of this tension, some municipal authorities and other authorities are using this as an excuse to actually evict refugees from whether buildings or campsites or other places. And this is, we're trying also to work around it and to see if this can be slowed down. All in all, I'm not optimistic, honestly. I don't think civil society, and this is a reflection, was able to or will be able to respond properly to these multiple crises hitting Lebanon and perhaps might spill over to the region. And I don't think governments, unfortunately, were able to respond, except for just reducing the outbreak or minimizing the outbreak of the disease. But when it comes to the socioeconomic implications of this, I'm not optimistic, and for the first time, perhaps Shadin knows this, I'm expecting really a down spiral in this area. Thank you.
Thank you so much. Each of our speakers have alternatively left us feeling a little depressed and a little hopeful. So let's take that combination into the discussion. Unfortunately, we have run a little bit over time. If you'll bear with me, we're going to run this session for another 10 minutes to give ample time for Q&A. And there have been many, many questions that have come in through the Q&A box. So what I'm going to do, taking the prerogative of chair, is just group some of them together and then ask our speakers to really respond to them. So we've had a whole cluster of questions that really relate to how social distancing can be implemented and adapted to both refugee camp settings, but also densely populated urban settings. And so that's a set of questions. There have been a number of them that our viewers would really like you to think about. And maybe that's something, Shadin, that can come to you. Related to that has been a question about shielding, which was asked, and how shielding operates as a strategy, by which I'm assuming, strict controls on coming into and out of refugee populated areas, camps, I'm assuming is what shielding means. We've had some questions as well about access to livelihood opportunities and how this is being adapted in the context of the response, and some questions that were posed by members of the refugee community, non-Syrian refugee community in Jordan, about how livelihood and really ensuring that refugee communities are able to access enough food, to be able to get through these closures and lockdowns, which was a central concern. So again, perhaps Nasser, you could also think about that. That's a question for Shadin, and these questions around social distancing and shielding, perhaps you could all be thinking about that. And then finally, in terms of the cluster of questions that I saw, there was one around the provision of mental health services and how that is being accommodated. So Shadin, perhaps you could think about that. Nasser, Goleen, I know you've been doing some initial thinking about how this climate of uncertainty will end up ultimately impacting our collective mental health. So those are a few of the questions that we've had. There are a couple more that I'd like to come back to, specifically on the situation of Palestinians and on sexual and reproductive health services. But I think there's enough there for our panel to think about. So I'm going to call on Shadin first, if you don't mind, seeing as a lot of these go to how you program.
Sure, thank you very much for that, Banat, and thanks to the participants for the interesting questions. I think in terms, there was one question specifically related to non-refugee population, non-Syrian refugee populations. And of course, as UNHCR, we always continue to advocate with donors, with governments, with all counterparts for a one refugee policy. So distinctions to the, ideally in principle should not be made at all based on nationality, but based on need. However, sometimes the reality is that there are earmarked funds that are coming for specific refugee populations as opposed to others. So we continue to work on advocacy for that with our partners and donors. In the meantime, however, we try to ensure that, or we do ensure that our cash assistance programs are based on very rigorous vulnerability assessments that take place on a regular basis, and that try to really identify the most vulnerable among the refugee communities, and those are the ones that cash assistance is mainly targeting. In terms of the other points related to service delivery, we are, to the extent possible, and this applies both to the mental health issue as well as other services, to the extent possible, we are moving to the virtual space, as everybody else is around the world in all types of settings. So we have really activated and strengthened our hotlines, for instance, in Lebanon and elsewhere in the region, where I think in Egypt as well. We are also activating networks of community workers and counselors and members of the medical community among refugees and outside from other communities who can support. And this is also relevant, of course, for people who are women who are experiencing gender-based violence and need that that counseling urgently, and it's a potentially also a referral mechanism for emergency situations. I think maybe in terms of the social distancing, yes, of course, it is a challenge. But as I mentioned, what we're trying to do is build additional structures that would facilitate that where possible. You saw in one of the photos, the whatever is applying to the population outside of the camps, we are trying to apply inside. And those who are living in urban environments are following the same rules and the same adaptations that other nationals are experiencing. So perhaps I will leave it at there for now.
Okay, wonderful. Any members of the panel would like to comment or pick up on any of those aspects? So the context of social distancing, access to livelihoods, provision of mental health services. Anyone else wanted to add to those comments? Either Nasser from the context of Lebanon or Golin?
I can just extend a little bit the discussion of the mental health services. Absolutely. I mean, it's crucial to continue those services when possible and to take them virtual when possible through hotlines or WhatsApp support or any other sort of virtual possibilities. I think the important piece is that we've seen this global discussion of uncertainty. Now everybody's experiencing uncertainty, but it's important to remember that forced migrants and refugees have been experiencing uncertainty for a very long time. And so this just adds to that chronic experience of uncertainty and is most definitely going to exacerbate mental and physical health problems. So I think the sharing of information and the transparency of information sharing is crucial to begin to combat that and chip away at some of that uncertainty. So absolutely, mental health is a huge aspect of this, and it's going to continue to be for the short and long term.
Great. Okay, so I am going to. Oh, you have one.
I'm just going to say a few words.
Sure.
You know, we witnessed this early on, and some would saying, okay, refugees are at higher risk. Of course, yeah, they live in crowded places. It's the housing situation or health or the shelter conditions are not optimal. But as a matter of fact, we didn't want to contribute to the victimization of refugees and to singling them out as people who are at higher risk. And as a matter of fact, and that's great, none of the refugees in Lebanon had the virus, or at least didn't test positive for the time being. So this is an important message because they're living in this condition. It doesn't mean, of course, if the virus goes in, they will be at higher risk or it will spread faster. But that actually was a strong position from us, particularly in civil society, not to spread this message because it will contribute to victimization of the refugees and to singling them out as a community at risk and as a place where or a population that would spread the disease.
Okay. Thank you, Nasser. So going to the next cluster of questions, which I fear may be our last cluster of questions. So we've had a number of comments on movement restrictions and how the intergovernmental organizations can engage with governments, not just in the MENA region, but one of the questions came from Greece, where movement restrictions are interpreted very strictly, and that impacts on the delivery of aid. And sort of allied to that, there was a specific question about how restrictions on movement are particularly impacting the movement of humanitarian workers. So perhaps again, sorry, Shadon, that comes to you, but it's something to consider. There was also a specific question on sexual and reproductive health services that I wanted to address to Goleen, really looking at how in this context of a real focus on respiratory symptoms, we can make good on our commitment to providing SRH services, which are particularly time-bounded services during the emergency. So, some sort of practical measures, perhaps, to ensure that those services are delivered while also respecting the need to combat the pandemic, and thinking about maintaining confidentiality in the process as people come and go to health facilities while the lockdown is in place, which really would exacerbate some of those existing issues. And then finally, we had a question specifically related to the situation of Palestinians, which was submitted by Dr. Akiro Saita, the Director of Health at UNRWA, and he was asking specifically how we can ensure full access to COVID-19 health services, including intensive care treatment for refugees, and what is the role of the international community in ensuring that host governments where Palestinian refugees are located ensure that kind of equal access to treatment. And he also asked a number of questions related to social distancing, which I think we've already addressed, and economic impacts. But this question of equal access to treatment and testing, I think, is an important one for the Palestinians and perhaps more broadly. So I will, turn to my colleagues on the panel and see if we can perhaps again start with you, Shadon, and address that question around movement and movement restrictions.
Thank you very much, Monette, and thanks also for the question. So it is a challenge. I mean, we do have to acknowledge that we are trying to find ways to address it ourselves as humanitarian workers. We are trying to request, where possible, humanitarian exemptions for our staff and our colleagues to have more ease to move within countries where there are strict lockdowns and curfews, etc. But for the moment, the restrictions do remain in place, and in many instances that means that we cannot do a lot of the work that we need to be doing. So registration, for instance, is frozen in many parts of the region. Documentation, issuance of any certification that is required, all of this is temporarily on hold, actually. So this is quite a challenge on many levels, and the implications that it has on other issues like potential employment, for instance, or refugees that aren't documented are less likely to have access to livelihood opportunities. So it has a lot of, it has a domino effect, actually. So this is something that we continue to work on with our partners and to see where we can lean more perhaps on local partners and civil society organizations who may have a little bit more leeway, but in most cases the restrictions actually apply to all. So it is a big challenge. There was another question, Monette, in relation to Palestinians. I perhaps would not be best placed to answer them, given that UNRWA is the mandated organization to deal with that. But perhaps among the other panelists, there would be that expertise and would be a readiness to answer.
Sure. So perhaps on the next question, Golene, I will go to you to talk about the specific question on SRH services.
Sure. So I think this is an argument that we've made for a really long time, even before this pandemic, that SRH services are an essential aspect of basic care. And so if there is SRH service provision in a refugee setting, it is basically essential and basic and should be continued and not disrupted with the additional care that's being provided for the pandemic. Now, that said, it's easier said than done, right? But I think really thinking about it in terms of basic and essential services is integral to the response, because what's going to happen in these settings is when you shift away from basic and essential services to provide pandemic response, you're actually putting the populations more at risk and making them more vulnerable. That ultimately, like, because of the numbers that we're seeing, while we're worried about population density and things like that in these settings, we're mostly worried about many of these populations not getting their basic needs met. And that leading to worsening chronic health conditions, poor reproductive health outcomes, all these sorts of other things. So I would argue that reproductive health service provision needs to be continued as part of basic health service provision. And all the efforts that are made to maintain confidentiality in gender-based violence service provision, so all the sort of hotlines and things like that, a lot of that still applies to maintaining confidentiality for sexual and reproductive health services. I would warn everybody that there's been quite a bit of discussion around supply chain disruption for contraception. So continuing to keep an eye on that. I mean, that will be very disruptive across the world in terms of SRH outcomes. But yeah, so okay. In essence, it's continuity of basic care.
Okay. Thank you, Golene. So in a sense, the last question on my list related specifically to the situation of Palestinians, but I think it raises the question of equal access to testing and treatment more generally for refugees. So Nasser, perhaps I could come to you to talk about strategies for ensuring that, you know, governments make good on their commitments and their preparedness planning and their national health plans to ensure that there is equal access to treatment for all. So Nasser, over to you.
Absolutely. I think this is a very good point made on access to testing and as well as to treatment. And we made this in a statement we put in with a number of civil society organizations on doing that. But you know, the healthcare system in Lebanon hasn't been operating in its best way. I mean, it has a lot of shortcomings before the crisis. It's highly privatized. Half of the population don't have access. They're not covered by any type of insurance. And when it comes to refugees, it's kind of subcontracted, if I can put it this way, to the refugee agencies, whether it's UNHCR or UNRWA or to civil society organizations. Of course, the pressure on the healthcare system is also significant in Lebanon. Lebanon managed to cope with the increased population, increased by 20-25% after the Syrian crisis and Syrians moving to Lebanon, but actually it mostly covered the primary healthcare. When it comes to the more advanced healthcare, it was short of doing that. And UNHCR was also, struggling to provide secondary and tertiary care for everyone. And UNRWA has been going with a lot of funding, restrictions, although the UNRWA system has been, of course, more developed than what UNHCR put, because it's been operating for many, many years in Lebanon, but still it's being compromised by the lack of funds and so on. So, things are not optimal, and perhaps the best advantage of the COVID-19 crisis that actually people have just realized the importance of a healthcare system that's publicly run, that's open for everyone. Refugees, migrants, citizens, working or not working, formal or informal, not tied to jobs or employment, and not tied to citizenship. And that's perhaps will help us in advocating for this more and more. Of course, just to be realistic, again, Lebanon is going through this crisis, so it won't be opening to this message or this ask with open arms, they're going to challenge this. But again, I think we have now an opportunity for us, people who work in this sector, who are in this area, to make this message quite strong and to push for it further, that it's now time to revisit the way we invest in public health and in healthcare systems for everyone.
All right, well, thank you so much. I mean, that is, I think a very important note on which to end. We have run over time. I'm sorry, I take full responsibility as chair, but these were such rich discussions and reflections that I thought it was really worth giving us the time to really air the issues. And the questions that you all posed were also incredibly rich. I'm sorry if we didn't get to your question, but I think, there are clearly some themes here that have emerged that I'd like us to think about. The question that I think we ended on how we, make good on universal access to testing and treatment, and the growing realization that we are all interconnected in our healthcare needs, through the systems that we create. The need for international cooperation more than ever, and a multilateral approach that I think Shadon called for, I think has been reinforced by this pandemic, and the need to counter that nationalist and temptation to close borders and to retreat really, I think, is a critical takeaway from this discussion. And then finally, the really important, I think, dimension, both from a public health and a humanitarian standpoint, but really for effective programming to take into account what we're hearing from the refugees and displaced communities that we're serving. That if we want to effectively address this pandemic, we need to address it in the places that are most marginalized. And in order to do that, we need to listen to the voices of the people we're serving. So I think with that, I will bring this to a close. I am told that the webinar has been recorded and will be available on the Columbia Global Center website and various social media platforms. So you will have a chance to replay this discussion. But thank you to the Global Center, and thank you to these wonderful panelists for today's discussion.